Hi, good afternoon. This is Korene Senior coming to you from Senior and Senior. Today I'm joined by Victoria Marie Shirley, who's going to have a conversation with me about everything long term care. Welcome, Victoria. Thank you for meeting with me this afternoon. Please introduce yourself to everyone.
Thank you, Corrine. Again, as Corrine said, I'm Victoria Marie Shirley. I have worked in the capacity of a director of social services for about 23 years. I graduated from Delaware State University with my bachelor's and master's in social work, concentration in uh, graduate school was in geriatrics. I always knew I wanted to work with the geriatric population, and I'm happy to be here. So thank you so much for having me.
Very good. Thank you, Victoria. We're going to start the night off with some questions I get very frequently from families that's considering long term care options for their loved ones. So I'll just kick it right off. The first one, Victoria, could you explain to us how the skilled nursing and long term care units differ in a nursing home? If you can describe a little bit in detail the kind of patients that would be admitted to one over the other.
Right. So let's start with the duration of skilled nursing care. So typically that could be someone coming in for short-term rehab. So that could be anywhere from 7 to 21 days. Um, and long-term care is really for those people who are unable to return to the community. So they could be there for a year or more, and they're not able to return to the community. The skilled nursing, the difference is that these people are coming for short-term rehab typically or a short-term need, maybe IV antibiotics, IV fluids, wound care, things such as that. Specifically to rehab, that could be speech therapy, that can be physical therapy, occupational therapy, respiratory therapy. Long-term care patients are pretty much again there for a longer period of time, but I don't want people to misconstrue the word long term as if they never can leave the facility. It just means that at the time that they're there, it's not an option for them to go home. But that can always change because I've discharged people who have been in long term care for some years back to the community. So that's pretty much the difference. So some people also refer to short term rehab patients as patients in long-term care, residents as residents.
Mm-hmm.
It's just a play on words, really.
Mm-hmm.
In reference to the kind of patients, really, I think the regulations say in a nursing home, I think the youngest that they can admit, I want to say is 18, the youngest age. I've worked with people as young as 18 and as old as 104 years old.
Mm-hmm. Mm-hmm.
Yeah.
I'm glad you talked about rehab in that skilled nursing facility because I do think sometimes people don't understand that that can be in one building, but you're getting two different services in that one building. So that leads right into that next question. Can you discuss how Medicare works in a skilled nursing facility? I know you talked a little bit about the days already of what's covered, but again, how long and what's exactly covered under skilled in a nursing facility?
Okay, so in order for your Medicare to be activated, you have the person, let's say the patient has to be admitted to the hospital, not an observation. And I'll just put this out there. A lot of hospitals have these special rooms that are extended observation days. No, the person actually has to be admitted, okay, for it to be activated. A 3-night qualifying stay, not an observation. Once that is activated, the person's Medicare benefit will activate over at a short-term rehab facility, what they call subacute. So hospital is acute, nursing home is subacute. If you have all your 100 days of Medicare, the day that you're admitted to the hospital, so let's say you got admitted to the hospital you were there for, let's say, 7 days, and 7 of those days you were actually admitted to a floor. Discharged maybe on your 8th, 9th day, that's fine. Those days are not counting down. Your days start to count down when you go into the nursing home. That will start at day number 1. And how Medicare works is day number 1 through 20 is covered 100% by Medicare. Your 21st day through your 100th day, Medicare is only going to pay 80%. The patient either will pay for the 20% or their secondary insurance will pick up that 20%. A lot of people don't know whether their secondary insurances will pick up. That's something that I advise people to look into just in case you should have to go into a rehab center. You already know if you're going to have to come out your pocket and pay the private copay, which right now is $185.50 per day.
Mm-hmm.
And that's as of January of 2021. This amount goes up every year, just so you know. So, and also, it's not very cut and dry to that either. You have to have what's called a skilled need for Medicare to pay for your stay. That is getting therapy. It could be just physical therapy. It could be just speech therapy. But all the therapies that they have, including respiratory therapy, is an option. Wound care. Wound care, a person has to have what they call a stage 3 or stage 4 wound. I won't go too much into that other than it's 4 stages of wounds. If you have a 3 or 4, that's what Medicare will pay for. IV fluids, IV antibiotics. If a person has a trach, if they're fed artificially by a feeding tube, things like that will keep someone covered under Medicare. Those are just some examples. Medicare does not pay for custodial care. Mm-hmm. Medicare does not pay for long-term care, which is custodial care. It will not pay for that, but it will pay for the skilled need. And that is determined by the hospital and the accepting facility of what skilled need does this person have. Okay, they need rehab. Well, we can skill them for that. Meaning skilled means Medicare will pay for it. If I could also add in there, not to confuse people, but if your secondary insurance is Blue Cross and Blue Shield Federal, it's great insurance, but it only pays 10 days into the copay. And a lot of people don't know that. And again, I find that a lot of people don't know. They may know about Medicare, but they don't know about that secondary insurance if they have it. What will it pay for? So I advise people to just call the number on the back of the card and see if you were in a rehab center, what would your insurance coverage pay for if you were in a skilled bed and getting skilled services. You have up to 100 days if you have a skilled need. After that, you won't have to pay the 20% anymore and Medicare won't be covering. Then you switch over to another pay grade, which will be either private pay or medical assistance, which is also known as Medicaid. So those are just some things about insurance coverage. And also, this is another thing I want to mention, only because I've experienced it with a lot of people. A lot of people feel that Medicare is going to pay for their entire stay while they're there for rehab. Mm-hmm. And just know that rehab sometimes, let's say it's physical therapy, sometimes they don't keep people on caseload for 100 days. For Medicare to continue paying for someone in a skilled nursing facility, there has to be progress made. So if you come in and you're not walking too much, but then you started to stand, and then you were able to take a few steps, that's progress. Now, if you stayed in the parallel bars and you couldn't advance anymore, then the team has to look at stopping, because Medicare is looking for progress. If a person starts to plateau, they're going to have to stop services. Therefore, that's going to end more than likely your coverage of Medicare. A lot of people don't understand that because they hear from the hospital, oh, you have 100 days. Yes, you may very well have that benefit time. It doesn't mean it's going to apply to your stay when you get there, because everybody progresses differently. So that's one thing to keep in mind with that.
Okay, that's good. And that's very thorough, because I do think I have families many times that feel like Medicare should pay for a significant amount of the stay. And I'm glad you touched on medical assistance and Medicaid because I wanted you to go in a little bit into how does Medicaid play into the whole spectrum of a nursing home? What is covered by Medicaid in that nursing facility if they have it coming in or if they have to apply for it once they get to the facility.
Okay. So let me go back a little bit too, because I just want everybody to be fully informed as best as I can. Please know we all have the right, if we have insurance company, that we can appeal the decision that the insurance company makes to stop payment. We all get those letters in the mail, and it comes in 5 different languages and says you have the right to appeal. The same thing works in a nursing facility if you're on Medicare. It's a law. It's a federal law because Medicare is federal. The facility has to tell the patient or the responsible party 48 hours before the last cover day that their insurance is going to end. And the person has a right to appeal. And there's 3 levels of appeal. I won't go into that, but just let me know what your rights are because a lot of people don't realize that.
That's true.
And then going into Medicaid, which is also known as medical assistance, and I'm only going to speak about this from the state of Maryland because that's that's where I've always worked. There is an option for people to stay longer in a nursing home and apply for Medicaid. I'm just going to call it Medicaid. It's medical assistance, but I'm going to refer to it as Medicaid. And basically, in the state of Maryland, in order to qualify for Medicaid, a person, I'm speaking of a single person, not a couple, because when a couple's involved, the equation of things is a bit different that I'm not well educated to elaborate on. But if you're single, you cannot have more than $2,500 in total assets. $2,500, $2,500. You can say it any way you want. Mm-hmm. Basically, you have to be destitute in order to get on state assistance. And the Medicaid specialists that are in the nursing homes will actually meet with patients or meet with the family members and ask them certain questions before they even start a Medicaid application. Because you don't want to go through a Medicaid application and find out you don't qualify, then you get penalized. Mm-hmm. So they can ask certain questions of the patient or the family member to see if a person will qualify for Medicaid. Now, they do have to ask about, assets, things like that. It's my understanding in the state of Maryland, they no longer look at vehicles as an asset. However, Maryland changed several years ago. They used to look back 3 years. They now look back 5 years.
Oh, that's good information.
And that's something that Department of Social Services wants to see 5 years worth of bank statements. The reason why they want to see that is to make sure that a person did not gift money away in order to get on state assistance. So if you're sitting on $50,000 and you had 10 grandkids and you kept giving money away because you said, okay, you take this money, you take that money so you could get on, you're going to need to go into a nursing home later in life, you won't be able to. There has to be an explanation of where large withdrawals went to. Like if you got repairs on your house, mm-hmm. and you could prove that, and it says it in the bank statement it was for Turner's roofing company, then that's fine. You can satisfy that with an answer. So with getting on Medicaid is not just qualifying financially, you have to qualify medically as well. So financially is pretty much more of a challenge because, again, several questions have to be asked by the business office to see if the person would qualify. But let me speak to medically. The person needs to have help with their activities of daily living, which is bathing, dressing, hygiene, things like that. So I think a person needs to have assistance in 2 or more of those areas in order to be on medical assistance. You can't be someone and I need to add this, it's not just about having a cognitive impairment. Okay. Let's say your mother can do everything for herself, walk, shower, but she has dementia.
Mm-hmm.
That's not going to get you qualified for medical assistance.
Wow.
You need to have help in those areas.
Okay.
And again, it's not all of them. And basically, what is done is a certain form that is done that is sent off to determine if this person would truly get a level of care. That's what it's called, a level of care. But going back to the financial eligibility, it's best to always be honest. I've had one gentleman who chose to not disclose that he had money. And when it was found out that he did, because they eventually find out he was given a private pay bill, which was thousands of dollars, which he could not afford. Even though he had money, he still couldn't afford the bill. And then it ended up with a hearing, and the judge sided with the facility, and I had to work on a discharge plan for that gentleman to go, obviously, to another facility because he couldn't go back to the community at the time.
Right.
But it's best to just be upfront. If you feel that you're not going to qualify financially, don't even try to do the paperwork because you don't want to be penalized. For those who are on medical assistance and you're staying long-term care right now, you're only able to keep $82 a month of your money. So let's say your income every month is $1,000. You only can keep $82 of that. Everything else goes to the nursing home.
I'm glad you brought that up. That's a question I get. Yep,
Yeah,
I get that a lot.
$5,000, $12,000, you're only able to keep $82. So it doesn't matter how much it is. However, if you are on disability, also known as SSI, now that you're only able to keep $30 a month.
Hmm.
So the $82, or if you're on disability, $30 a month, that's for your personal spending. You can use that for anything you want. It does not go towards the nursing home at all. So if you want to use that to buy toiletries or what have you, that's for you to spend. The medical assistance amount has gone up. It goes up over the years.
Mm-hmm.
The disability has been $30 since I've probably been doing this, 20-something years. That doesn't go up. Because typically people on disability at baseline get about $700.
Okay.
So the state takes all that and just leaves them with $30. Hopefully I explained that well.
I had a follow-up question to what you just said. When a resident is on disability and they're living in a nursing home, these are generally folks that are under 65, correct? Because they don't have regular Medicare. It's disability.
Right.
Okay.
Right. It can be, yes, absolutely. There are. I worked in a facility. A lot of my people who were on disability, if they were under the age of 65, due to health issues that put them, they were unable to work and was qualified for disability. Yeah.
You talked about a lot about the money that they get to keep, which is important because families usually ask that question right away. Do you know, Victoria, if this is in your wheelhouse, if it is certain things they can purchase? I know you said repairs on a house and toiletries, but if they have funds available but they're trying to qualify for medical assistance, can they pay for the burial, the prepaid burial, or is that not okay?
That's a great question. And yes, you can. You can spend money as long as it's towards. Okay, so when I was speaking about the roofing, I was speaking of that as if that had already happened in the last 5 years.
Got it.
Now, if someone wants to use that money for themselves, for the resident, for example, the resident needed new clothes, then they can have that. If that resident wanted a new computer, they can have that. A new wheelchair, they can have it. When people were applying for medical assistance and they were going through what's called a spin down, I encouraged people, their loved ones, to buy things for the resident that they need. Geriatric reclining chairs that we see around where they recline back. You know, the standard color back in a nursing facility was blue. They always had a blue. I said, well, go out and get the maroon one. That would be that your loved one's personal one and will have it labeled, and that's money spent for that. Clothes, the radio, the CDs. I had one gentleman, lady who was on a ventilator, but she could still speak, and her brother was a dentist, I think, in California, and I helped do like a FaceTime thing with him, and I said, you know what, you got to spend down money for her. Well, why don't we just go and get her a laptop and she can video record with you all the time? And that's what we did. As long as you show your receipts, that is acceptable. However, medical assistance is not going to want you to pay your bills if you're not in your home. So that cable bill, that phone bill, no. And as far as the home is concerned, it depends on. Sometimes the house is not considered an asset, and that could be because a spouse is in the house, or there is a dependent child in the house. And I'm not just going off of age that somebody's 11 years old or under the age of 18. You can have a child that's 55 years old that needs support, maybe because they have a certain condition. So they don't look at a house as an asset at that time. So that's something that should be kept in mind. Also, it's about the paperwork again that the nursing home does. Some people will say, well, I want to apply for medical assistance for a short period of time with the hopes of going back home. There is a form that the doctor does that says the person's going to be here 6 months or less, or it may say 3 months or less. And medical assistance will not look at the house as an asset. Let's say if nobody was in the house, they won't look at it as an asset because the person has to have somewhere to go back to.
Okay.
But again, it depends on how that paperwork is filled out by the doctor and what is the patient wanting to happen. Do they really think they're going to be there long-term care for like a couple of years? Or do they really think, okay, they got through rehab, but they're probably going to need another 6 months and I need to apply for Medicaid, but I still want to go back home. Then the doctor just writes that down. Yes, they still need to do rehab, be home in less than 6 months.
Okay. Yeah. That's really good because I also get that question too about what if it's just short term or what if they need to go in long term, but we still want mom to go back to this house. So it's like they're juggling what to do with insurance while, knowing what to do with the house at the same time. It sounds like also, Victoria, you mentioned the business office manager. That person in a nursing facility can help facilitate as well some of this financial, just kind of logistics of what to do, correct?
Absolutely. The business office manager, or they call them finance workers, or the Medicaid specialists. Definitely those are key people to speak to. And I suggest sooner versus later. So if this is what you need to proceed with or not. But again, go in knowing that they will ask certain questions that you may feel uncomfortable answering, but it's all to help to see if you can get this benefit. And some people come into the nursing home already have community medical assistance, which is good. And then the nursing home just converts that from community to long-term care. And then when they're discharged, it goes back to community. So that's good if they already have medical assistance, in place. Just go in, ask the questions. They'll ask you the questions and see if you qualify. Some people really can qualify. I mean, that amount of money is very low to not be able to have more than $2,500 in total assets. Yes. I will also say this: if you're someone who has money, I suggest you seek an elder care attorney.
Okay, that's great advice.
Absolutely, elder care attorneys. They're all around in Maryland, especially in the Baltimore area. Very good firms who are able to somehow get people approved for medical assistance.
That's good.
So,
You know,
and again, it may be a spend down process to a
right.
degree,
Mm-hmm.
but they specialize in getting people qualified. They sometimes will do the whole application for the Medicaid as well for
Mm-hmm.
medical assistance. So that's that. I would suggest that for people who definitely um, may have a means to pay private pay for a nursing home, because typically, and you didn't ask this, but typically a nursing facility these days private pay probably is between 11 and 13,000, maybe $14,000 a month private pay.
A month. Wow.
400 something dollars or 300 something dollars a day. So it is very costly. And again, that's why the state only allows people to keep $82, because your maybe your $2,000 check that you get a month is clearly not going to pay really the private pay.
Mm-hmm.
So that's why they only let you keep that little bit of money. But please know that if you are on Medicaid, full Medicaid in your long term care, and let's say you only get your $82 a month out of your $2,000, when you are discharged, you start getting your full benefits back every month. A lot of people don't know that.
That's good. And I wanted you, I'm glad you talked about discharge because I wanted you to talk about what that looks like for those residents that don't need to stay in a nursing home. And they do have the funds, or they qualify for Medicaid either financially or clinically. How does that process look when it's time to discharge? Can you talk about how you've helped families with making the choices or making a decision to go an alternate route because they didn't need to stay in a nursing home after their rehab?
Right. So a few options. People are able to go back to their previous placement. Some people are go with family or friends. Some go to group homes or assisted livings. So I will speak to people going home first, or back to their previous setting. Pretty much, the social worker is a discharge planner in a nursing home, and they arrange for home health services that Medicare will pay for your therapies 3 times a week, and nursing can come out 2 to 3 times a week. Again, that's not every day, and that's not long standing, but it gives somebody some support when they get home, to have home health services. Um, Another uh, placement option is assisted living. And assisted living is the in between point of being in a nursing home and being in an independent living situation. So, an assisted living typically is a facility in which there are apartments in which people live there, and they have 24-hour care there. They have the nurses, they have the aides, they have therapy there as well, but it's a step down from a nursing home. Um, is not as regulated as a nursing home. That's one thing. Um, Typically, they are strictly private pay. Not unless you
Mm-hmm.
have long-term care insurance. Some people
Mm-hmm.
have long-term care insurance policies that says that it will pay if you were in an assisted living X amount of dollars per day. So that could be a situation as well. Um, that person has their own apartment. They get the assistance that they need. They're engaged in activities. They go out on trips. Um, they usually eat in a common area, 3 meals a day. Um, you still could live a full life in an assisted living situation. You just need someone to still maybe manage your medication or
Mm-hmm.
assist you with your bathing, dressing, hygiene, which is again your activities of daily living, also known as ADLs.
Mm-hmm.
Um, that's an option. Also, I presented to people when a person really didn't want to go into an assisted living, they wanted to go home, but I suggested what's called a respite stay, which is a short-term stay. Typically is 30 days, but it could be 90 days in a assisted living, because maybe the facility said, it's our recommendation that you really just go to an assisted living. But if you're your own responsible party, which people are, we only can give the recommendation, document it, and that's it. But I have presented to people, okay, well, what about if you try an assisted living for about 30 days to see if you like it, a respite stay? And typically, when people do respite stays, they don't have the apartment is already furnished for them. They go there to see if they like it or not.
Mm-hmm.
That has been very helpful to people to really see if they'll be able to manage like they thought they would if they went home.
Right.
So that's an option as well. And as far as group homes, also known as assisted livings as well, but let me be clear on something. For something to be an assisted living, and I will speak to Maryland, it had the facility or home, it could be a house setting, has to be licensed and bonded. So there are a lot of group homes out here. There are a lot of assisted livings that have that will take in patients that do not have the license to take care of people. So be very careful if you're looking for an assisted living or a group home that is a house setting that you see a license. There was some issues years ago, and now it's this whole list that is put out by, I believe, the health department that lists all the approved house setting group homes, assisted livings, because people were branding themselves as assisted living, they were not, and people were not taken care of, and it caused problems. And you know, you really want to safeguard people, make sure you're putting them in a licensed assisted living setting. Sometimes those home settings are less money, just so you know, versus the first example that I gave, the facility type. Some of them also accept Medicaid as well. Social workers in the nursing homes, like myself, people who were there. I had people who were, I think I successfully sent home maybe 7 people or so to a group home setting that was licensed under the Medicaid waiver program.
Oh.
And it is doable.
Okay.
It is doable because the state wants to see people back in the community. And that's a good way to go. And some places have X amount of beds that they approve for Medicaid waiver people, and they get all the assistance that they would need if they were in a larger type of facility, assisted living.
Right.
So those options as well.
And I've seen some of those group homes. Sometimes, I mean, they're just what that resident may need, depending on what the preference is of your loved one. Sometimes that one-on-one interaction in the smaller setting works out perfectly. So I'm glad you brought that up.
Yes. And you know what? Some people who are not licensed can give very good care because they were in the caring profession. You know, the healthcare profession could have been a retired nurse, and that person wanted to open their home up and take in 2 residents, and everything's fine. But just know that those that are licensed are surveyed.
Right.
And there's certain things that have to be looked at, temperatures, the meals, things like that. The survey is very important as you're shopping for a nursing home, whether it's short-term or long-term, or a group home or an assisted living. These places are surveyed, and it's all online to look at to see what the surveys have been in the past.
And yes, like you said, everything is online. So I like to bring that up as well. It's important to do your due diligence.
Absolutely.
So another question, because we did talk a whole lot about the financial aspect and insurance and how that looks. I am not a licensed therapist, and I know you're not a licensed therapist. However, we've worked in this industry for quite some time now. So what can you tell me about some of the emotional preparation that should be taking place if you notice that your aging parents are needing more care, and this may soon be an option for them to seek out long-term care? What can we do as an adult child to say, let me prioritize and get mom or dad ready to potentially make this move? How can I, get myself in my mind and emotionally ready for this next chapter?
Well, that's a tough question. I hear stories all the time, and one of the stories that's pretty common is that my mother made me promise that I wouldn't put her in a nursing home, but I can't take care of her anymore. When she said that, she thought she was going to be okay, but now she has dementia. She can't walk, and when she tries to get outside in a wheelchair, it's after midnight, and the cops had to bring her back to the house. And sometimes it happens, things happen in a crisis. And what I do with family members is I talk to them about being proactive and not reactive, so that you can have a choice in where you want your mother to go. You've toured the place, you're comfortable with it. And again, if you go to a place, it doesn't mean that you're married to it. You can always, the person always can be moved. But I try to have conversations with people to don't turn a blind eye to something. If you start seeing a decline in your loved one, then it's time to have those conversations then. It's time to put things in place, final arrangements, things as far as taking care of your funeral, the cemetery, your advance directive, which is a healthcare power of attorney, your living will, a will itself, things like that. And the time to do that is, again, not in a crisis. It's not when the person is having a depressed state. It's when the person is well to have those conversations. Ask them what their wishes are. Now, if you had to go into a nursing home, is there any place that you would want to go? You may want to go into a retirement community where they have all 3 levels of care, the independent living, the assisted living, and the nursing home section. So that if you start to decline and you go into independent living, then you go to a higher level of care, which is the assisted living, and then the next higher level of care will be the healthcare center, and you age in place. So those are options as well, but it's I know it's a difficult conversation for people to have, but I've seen people unfortunately be reactive instead of proactive, and it doesn't do the resident any good or the patient any good. And it doesn't do the family member any good as well. It's important to have those conversations and just plant that seed of what should I do if X, Y, and Z happens. I've had family members. Right now, I'm a resident services coordinator for a well-known retirement community in the Baltimore area. And I've had family members call me and say, okay, my dad is the person who really is caring for my mom, but he's declining himself. I need to think about what's going to happen to my mom. If something were to happen to my father today, she can't be in the apartment by herself.
Right.
And it's those things that these people are. Some people are not putting a blind eye to it, and they want to try to work on what should I do now to kind of prepare. What are the services that are provided to safeguard my loved one? If my father just went to the hospital to have a knee surgery and I'm out of the country, what can my mother have to safeguard her in the time that he's away? So it's very important to have those conversations and to be upfront. And listen, it's not something that you have these conversations all at once. It's over time.
Good point.
And some cultures, just to share this, some cultures actually will take care of their loved ones for a very, very long time. And by the time they actually relinquish taking care of the person and they're in the nursing home, the person is severely demented, even with behavior sometimes. I've seen that happen. But again, you're dealing with different cultures and how they do things. Some people are very good in planning their future with legal documents, seeking an attorney, an estate planner, things like that. And other people, it's not something they've ever talked about, educated about, and they just don't know. So, again, conversation is the key with your loved one. And if your loved one says, promise me you won't put them into a nursing home, I'm not telling you to tell your loved one you won't promise them, but keep in mind, I've had people like in tears because they said, my mom told me not to put them in a nursing home, and here they are.
Right.
Well, your mother said that she wasn't thinking she was going to be in this state either.
Correct. Correct.
And you, if you could take care of her, you would. I'm sure you would.
Right.
Mm-hmm.
Well, very good. We touched on so many great topics. Victoria, thank you so much. I did want to give you an opportunity to share any final thoughts you felt families should take away. We covered so much, but is it anything that you'd like to leave for families at the end of this meeting?
Um, un- we all age, and we age differently. It Make sure your loved ones go to the doctors, they get the care that they need. You are their advocate, whether you're not living in the same state or you're right there with them in the same state. Find out what's going on with them, making sure they're okay. I've had people who, one family didn't know that their loved one was a hoarder because they always met them downstairs.
Right.
Keep in mind the person was confused and got lost all the time, and the family had no idea about it. Actually see your loved one, even if it's by video. You know, technology is here. It's wonderful. Use it. Take care of estate planning. Take care of your advanced directives. Have the conversation about finances with your loved one. What do you want to see happen to yourself if daddy wasn't here, if mommy wasn't here, or if I wasn't here? What can I do for you if I'm not here? Or if I'm here, what do you want? What are your wishes? And that's what I have always focused on, being a director of social services. What are your wishes? Because if you're your own responsible party, I will give you the recommendation, but ultimately it is up to you.
Right.
So again, try to be proactive and not reactive. A lot of people tend to do things in a crisis, and it's not good for anybody. You can't prevent crisis, but if you put a plan in place, if a crisis happens, hopefully things will open up and you can go from step A to step B to step C, and it won't be so traumatic. So that's my takeaway for that.
Well, thank you again, Victoria Marie Shirley. Thank you for having this conversation with me today. I feel like families will leave being proactive when they listen to this conversation, because that's what it's all about. And that's why we're trying to get this message out for families to just prepare. So, yeah. I look forward to having you again, Victoria Marie Shirley at Senior and Senior, and I'm Korene Senior, and I'd like to say good night.
Good night. Thank you so much, Korene.